Hello, welcome back. We are now at room number 4. On my right side, Dr. Fava, Dr. Juan, Erika as a technician, Axel as a nurse, and Claudio also a technician, and Valeria, no, Victoria, te cambié el nombre, sorry, and Victoria, our anesthesiologist, helping us with this case after this first very tough case. Okay, let's, Andres Rodriguez, Dr. Andres Rodriguez is going to help us with as a digital moderator with the questions. So Andres is prepared. I would like to ask to everybody to bring questions. So let's see, this is a complex LAD and left circumflex PCI. The next slide, please. So this is 72 years old, presented with chest pain and palpitation. He suffered from hypertension and dyslipidemia. Next. On the ACG is on the normal sinus rhythm with the right bundle branch block, with the first degree also of AB block with 220 milliseconds on the PQ extension with frequent supraventricular and ventricular extrasystoles. The blood tests are normal on the basic blood test. The echo Doppler evaluation show the preserved left ventricular ejection fraction with the 62%. With some hypertrophy. On the 24 hours Holter monitoring, there's going to be some extra bit that I will show you in the next slide. On the stress echo, he presented angina and also a significant ST depression at the maximum effort. So that's why the stress test was stopped with a significant hypokinesis on all the anterior and anterolateral wall. Next. So this is the ACG with all the findings I have already described with this first degree AB block and the right bundle branch block. Next. This is the Holter, the ambulatory Holter monitoring with some extrasystoles bimorph with some doublets and triplets of the extra bits during this evaluation. Next. So for all that reason, this patient was considered as a high risk for ischemic disease, considering that he was symptomatic with arrhythmia, with the changes on the ACG, sorry, and with a significantly positive stress test. So the patient was referred for angiography. This is the big right coronary artery with diffuse disease, but not significant stenosis in our consideration. Next. And here we observe an epicranial view without significant stenosis on the right, but with significant calcification. And on the right side of the panel, you can observe a very tight stenosis on the left circumflex and a very significant stenosis on the proximal LAD, where it's a bifurcation with 1 or 2 diagonal branches. Next. There you can observe calcification, tortuosity, and tight stenosis on the proximal LAD in both projections, epicranial and LAO cranial. Next. This is the spider view. Once again, this is a very tight stenosis on the proximal LAD, and then the bifurcation after the stenosis with these 2 diagonal branches. And on the right of the panel, you can see right cranial and oblique inclination, where we can observe a little bit much better this very significant and calcified and tortuous proximal stenosis on the LAD. Next. So the syntax score of this patient, Dr. Fava calculated on 26. Click, please. So according to the appropriateness of the indication of revascularization, click, Andres. This is an appropriate indication in a patient with 2 vessel disease with a proximal LAD, according to this publication from 2012. But next, according to recommendations from ACC, AHA, and SCI, and all the American societies, the indication is 1A for cabbage and probably 1B or 2B, sorry, for PCI. But according to the European guidelines, In patients with proximal LAD stenosis, the indication of PCI is 1B, sorry, for surgery, 1C for PCI. Next. So once again, the indication, in our opinion, considering the proximal stenosis of the LAD, two-vessel disease in a symptomatic patient, the indication of PCI, or actually the revascularization, is appropriate in this patient, although it's a chronic coronary artery disease, unstable. Next. According to the indication of also the European guidelines, there are some, factors favor on PCI and other favor on CABG, probably the syntax score for this patient and also young patient without other contraindications would favor surgical revascularization. Next. So at the end of the heart team discussion, CABG was considered probably the best indication for this patient, but he refused surgery and he chose to undergo PCI. We agree on that this is an acceptable indication, probably not the best, but it's a good indication if we can treat this proximal LAD and then the left circumflex, and then we put the patient on optimal medical therapy and we keep a very, close follow-up to see how is the evolution during the time. Next. So we have prepared for radial access. Dr. Carlos did the radial access. We are going to predilate and to put stenting on the proximal LAD, and we will try to be provisional. So let's move to the lab. You can share the monitor views. We are going to advance the guiding. This is not the guiding I like the most, but this is the guiding that we have. Let's move up. Okay. Oblicua derecha. So significant subclavian angulation. Dame el conector, así no ponerlo ahí. The patient is sleeping, so he's not going to collaborate too much with us. Anyway. Managing, mostrame el tronco. So we might have comments about the indication or questions about the indication in this patient. Probably first, without taking into account that his consideration, and then of course we have to consider patient's preference, because this is the most important thing in our practice, to hear and to discuss honestly with the patients which would be the best strategy. Test. Okay. Think. Test. I'm going to have a good support. It's okay. Izquierda, derecha craneal. So here we can observe the calcium. We are dealing with a lot of calcifications today. So we are going to use the regular BMW wire. We are going to cross this lesion, and then we will decide whether to do IVUS or to predilate and then to put a stent and to do IVUS to have a better decision about the final outcome. So probably a little bit más oblicua derecha. Okay. Vamos a hacer. Let's do another test here. Yeah. Here is a little bit better. Okay. No, que no se me mueva. ¿Ves? Téneme la mano, Juan, un segundo. La mano. Oh, Valeria is going to take care of that. The patient is sleeping, but is moving. Please, hay que quedar quietito. El pin. So here the discussion would be whether to protect these small diagonals or let's go undoing and then fix it if we have problems. Test, Carlos. So fortunately, the wire is advancing smoothly, but I will need probably a balloon. We are going to use broad med balloons from China. They have FDA approval. The Artemis balloon, we can use a 2.5 Artemis en la caja que te trajeron. Artemis. Bueno, fíjate uno que se llama Artemis. ¿Qué diámetro es? Ok, 2020, 2.0 by 20. So with the using this balloon, which is a low profile balloon, is one of the lowest profile, is 0.016. We have diameter from 10 to 4 and length from 5 to 30 millimeters. This is a compliant balloon, very low profile. It's good for helping to cross and to predilatation. Then we have other balloons for non-compliance that we are going to use afterwards. So, Carlos, would you protect the branches or you go?
No, I go because
Okay.
It doesn't have a.
I don't like the support that I have with the guiding, but it's not time to change it now. So, te diría que tengas a mano un Godzilla, un telescope. Let me advance the wire a little bit more. Let me advance the balloon. Let me push the wire. I have a more stable situation. Let's inflate the balloon. And then after the inflation, we can use the IVUS to see which is the diameter. Again, deflate. Let's care a little bit about this curve. You see that I have resistance there. And this is a company guiding that I don't like because the backup is not perfect. Okay, inflate there. Deflate. This is a 2.0 balloon. Okay. Or we should have used an extra support guidance wire. Dame el otro 2.0 que tenés ahí. El 10. O 15. 2.0 by 15. So for sure, this tortuosity is going to be a problem. It's something that we predicted because we have the tortuosity and the calcium. We discussed the possibility of doing rotablator, Rotapro, but there's a lot of tortuosity there. I scare a little bit to damage the middle segment on the diagonal after the first bend of the vessel. So to be honest, I don't like to use it in this situation. Let's go. We don't have support. Give me the telescope. We don't have a good guiding support. Let me try to improve it with a guide extension. In this case, I'm going to use the telescope from Medtronic. Not, we might have to change the guiding. Give me the balloon. Okay. So any question, Andres, there? Let me see where I can reach with this balloon. Oblicuo derecha, convencional. Mostrarme el guiding. Show me the guide. Let's see. This curve is gonna be a huge problem. Okay, now we are better. It's important to use. And now we have the axilla there. Inflate, Carlos. Let's go. Volver. Deflate. So the profile of the balloon was okay. And this is the maneuver we use to advance axilla when we had to go for a deep intubation in flying. Okay, deflate. I think it's not gonna be easy to advance the IVUS. Try again. Okay, deflate. We will try. If not, we are going back to the balloon to advance the guiding, deploy the stent, and then we control the stent. Well, this is an interesting question. Here in Argentina, to use, we don't have impeller first. So the only left ventricular assist device for this PCI would be an intra-aortic balloon. We are not using too much. You might have observed the case we did in the other room, unprotected left main with the total occlusion on the right. And if you work fast, I think in most of the cases you don't need it, but you have to be prepared for using. In the case of emergency situation, I would have to use the balloon. We haven't thought about that because we have a huge right coronary artery. So with the patient, we preserve left ventricular ejection fraction. So I think this is not in our regular practice to use an left ventricular assist device. Camilo? Probably because of the limitations and also because the history that we haven't had. Oh, well, we are successful. So we, no, let me see. Okay. Okay, could you show the IVUS, please? Wait a minute. Wait a minute.
Okay.
Could you show the IVUS? Okay, let's go. Let's go, Gustavo.
Okay.
Wait a minute. Wait a minute, Gustavo.
Yes.
Now, again, start again.
Well, we are live.
Okay, we are live. You can describe.
Yes, we are the middle segment of the LAD, isn't it?
Yes, absolutely.
We can see an eccentric plaque, a mild eccentric plaque, 5 to 8, then a severe plaque with a severe calcification, superficial and deep calcification. This is a bifurcation.
And this is the proximal LAD.
The proximal LAD was also
the tightest stenosis there. Calcified.
Yes.
Okay.
We have a very calcified lesion.
And then it's gonna be, this is the
left main and the ostium. Yes, with a mild stenosis.
Okay, great.
So we are going to first see the reference diameter. It is. So
I think here, after, while Gustavo is preparing the measurements, we had to decide what to do. Let me tell you what I would do. First, I'm gonna pre-dilate on this curve, which is proximal to the reference segment that Gustavo showed on the IVUS with only middle plaque. So we have there a 2.5 diameters on the vessel, probably 3, with a tight and concentric calcification. So there we can use an Apollo non-compliant device, 2.5 by 20 or something like this. This is a non-compliant device from Brosmed. This is only 3% axial growth when you inflate at very high pressure. The average burst pressure is 30 atmospheres. The diameters that we have is from 2.0 up to 5, and the length from 6 until 30. So we are going to use 2.5 by 20.
20.
Okay. So I'm gonna go distally. Then I'm gonna use, if I have a 3.0 cutting balloon for the proximal calcified lesion, and then I'm gonna deploy the stent with the help of the telescope device. Buscate un cutting 3.0. ¿Cuánto es el diámetro?
So the distal segment is 2.8.
Vale,
The middle segment is
Okay. You see, display.
3.7,
Okay.
and the minimal lumen area
Okay.
is 2.8. Okay, that the area.
Okay, so we can inflate there. We have the tight calcification, a 3.0 cutting balloon. Let me add, tenés el 3.0. Okay, so let's leave the balloon there. I'm gonna advance the telescope device. So because the profile of the cutting balloon is absolutely worse than these balloons. So keep this 2.5 a high pressure balloon there. Give me the cutting. So it's a very complex anatomy, and we are trying to be as simple as possible. More complex the lesion, more simple you should be. Of course, if possible. If not, it's an error. Yeah. I know it. It's gonna appear this question. This is gonna be a good case for intravascular lithotripsy for sure. But unfortunately, we cannot use it because we don't have authorization in this case. You can inflate there 3, 4. No more. 4, 5.
Right.
It's okay. Deflate. This is the 3.0 cutting balloon. Thank you for the question. I think it's a right question. This is gonna be the best option probably in this situation in flat.
4, 4.
Yeah, but sometimes we have to deal with inflama 8-10 with our local limitation. It's something in a way this plate is broken. I think it is something important because in a way we are showing to you how to overcome local limitations, because this is a main difference probably from MedStream and live casing from other live demonstration where you work and present the ideal situation. Here is the real situation. What you would like to do it, what you can do it, and how you do it to get a good outcome for patients. In my opinion, this is one of the, dame un 3028.
Anyway, as we saw at the IVUS, a deep as superficial calcification, I think that cutting balloon will be the right option. Do you think so?
Yeah, probably yes. It's also an option here. It could help is the other ablation device. Rotablator is not an option, although the wire now looks very straight. There's a significant curve there. And I don't know what can be the outcome of the rotablator. Probably we can have a perforation. It's something that I don't like to have it on live transmissions, not in the real life, of course, also. So this is, the significant change on PCI when you have the possibility of using this guide extension test.
Do you think 2B, 3A or other drug will be useful in this case?
No, I don't. We don't use it in our real life 2B3A inhibitors. I'm not convinced about the benefit. And also, they are almost not in the market of Argentina. It's a very unusual situation for using. So a little bit distal to be sure I don't have to get back. So test. Okay, let's inflate there. 1, 2, 3, 4, 5. Mostrame. Hace play, vos infla. Okay. Okay, perfect. Wait a minute. Sí. Wait a minute, Carlos. Deflate. Okay, which stent would you use, Gustavo? 3.5 or 4?
3.5.
Okay, give me a 3.5 by 24. That's okay. So I use the balloon from the stent as a support, a protection to advance the guide extension so that I have a perfect position in there. So it's going to be easier to advance the 3.5 stent into this curve. That's would have been difficult with this guide support, which is actually very weak.
I think that the 3.5 will give you a better navigation inside the vessel, and then you can go up to 3.9 through 3.8.
Absolutely, which is
And
absolutely. So something that we are not doing here, but because I felt that it advanced very smoothly, is to check when the stent is entering into the proximal part of the guide extension. So I will leave the stent distally, sorry. I will pull the device. I will do a test to be sure which is going to be the position for deployment. So we are quite far away. Have to go back, test. And now we can go to spider view. We have a lot of small branches. Then we will decide which one we should rescue, test. There is a huge diagonal there that hopefully is not going to be compromised because with the guide extension, I cannot use two wires. Test, Carlos. This is one limitation of the guide extensions. So probably I have to go a little bit further. Test again. Sorry, again. Oh, again. Okay, I feel better there. Okay, inflate. 1, 2, 3, 4, 5, 6,
18.
10.
the importance of the guiding catheter in this case is
Deflate.
they're very important because it not also help us to get any device inside the artery. Also, if we have a perforation, to help us for the stent graft also.
Absolutely. Yes.
In these tortuosity arteries.
So as you can observe, the diagonal it's perfect with an absolutely normal flow. I don't think so. We have to go for a kissing balloon there.
No.
What I would do is IVUS on the LAD to see if I need post dilatation there. So bring me the IVUS. So this is, in my opinion, a good demonstration of how to be as simple as possible in a complex anatomy with the guiding, which is not helping you too much. So we have problems in Argentina a lot. One of them is that we don't have good guiding catheters. Companies are not investing money on develop good guiding catheters. Inject a little bit. I am out. Okay.
Nitro.
Okay. Give me some nitro. Give me, Carlos, you can do it. On the wire. So Dr. Lewis here. This is a clear message for everybody who were watching the other case, that everything went okay, that all the closure devices worked, and the patient is going to the CCU now because the left main and all the interventions we did, some of them totally unexpected. Okay. I was coming quite smoothly. And now let me give some nitro. Where is the nitro? Okay. And then we wait for a second. Le estamos dando nitro. And then we can go with the pullback.
Okay.
You
So
need to go
we begin the pullback.
A little bit distal, no, Gustavo?
Sí.
Sorry.
You need
Okay.
to go a little bit distal. There.
Okay. Okay.
Let's go there. From there.
Okay.
Let's go.
So
You can
the-
describe, Gustavo.
So this is the middle segment of the LED, isn't it? Yes. This is the stent. It has a very good apposition and a good expansion. Perhaps a bit
There is the bifurcation
expansion.
with the diagonal.
Yes.
There you have the diagonal. And this is the proximal segment of the LED. Probably
it needs more diameter.
Yeah.
At the middle segment of the stent.
So it's 1, 2, 3, 4. So prepare a pot PTR non-compliant, which is a pot balloon for the pot. This is you have the term, the name is pot. Okay.
Okay. So we need.
Okay, give me this. This is a short balloon with short shoulders. This is important for pot, especially when you are doing bifurcation. Remember, this is a Chinese company, Brosmed. This is the first time we are using this balloon. We are pulling the guiding out, the IVUS out. Dr. Levi is going to review and going to tell us if we have to post the late proximally or until, or up to where. ¿A dónde tengo que llegar, Gustavo?
So this is the reference diameter.
Wait a minute.
And this is the segment you have to post delay.
Okay. I got you. Give me, okay. We still have 15 minutes.
Yes.
And we have the left circumflex to do it. I don't know if we're gonna be on time for finishing. I will try to rush a little bit, to post dilate to IVUS and then go to the circ. Let's go, Carlitos.
There is a big difference between proximal and distal.
Okay. 1, 2, 3, 4.
Lumen diameter.
To distal, no more. 5. Okay. So there. 1, 2, 3, 4. 5, 7, 8. Deflate. There. 1, 2, 12. 12. 12. Okay. 14.
14.
Okay. It's okay. So we have used the same balloon, very short balloon, a little bit distally, a low pressure, and then proximally a 14 atmospheres inject. So angiographically looks perfect. Let's check by IVUS once again. This short balloon is perfect for post dilatation, especially when you want to post dilate in a short segment without affecting a bifurcation. So give me the IVUS again, and then prepare. Show me la primera geografía en oblicua derecha to see the circumflex. No, en caudal. No hicimos. Okay. We have to see how the circ is and how fast we can go, but I think it's nothing special about the circ. Probably the more complex lesion was this proximal LAD lesion with such calcification, tortuosity, bifurcations near the ostium, and so on. And we did it as simple as possible. Now we have difficulties to advance the IVUS, but this is the area. Let's go from there, Gustavo, please.
Okay, pull back.
Yeah. I help you. This is the area we post-dilated with 4. It looks much better. This is bifurcation with the diagonal. And here at high pressure. And we are near to the ostium now. And this is the ostium. And this is the circ. And this is the left main. What do you think, Gustavo?
I think it's okay.
Acceptable, not ideal.
Sorry?
Acceptable, but not ideal.
Yes, you're
according
right.
to the IVUS. Yeah, I know.
Yes, you're right.
But, you know, I can dilate a little bit more distally once again, and that's it.
Yes.
Not IVUS. And then I'm going to go to the circ. Dame el balón de vuelta.
The distal segment of the stent is quite okay, but there is a bit of expansion at the middle and proximal segment of the stent. You can see now.
The problem is there is the tortuosity, Gustavo.
Yes.
So this is what I scare a little bit to overstretch there, because we have a rectification, we have the calcium and so on.
You're right.
And probably I could.
And the risk of perforation also.
Yeah, a little under expansion there. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, deflate. 14, 16, 18. Okay, that's it. One injection here. Inject. Okay. Inyecta. Let's go to la craneal y vamos a hacer un stem boost de ahí. Vale. Apuremos que me quedan 10 minutos. Yeah, that's what I was talking about here. Is much easier to understand. Where Dr. Lev can observe some under expansion is exactly there on the curve.
Mm-hmm. Anyway, the area is 8.2, so it's a very good result.
Yeah,
isn't it?
Yeah,
so
absolutely.
I think that we can leave it like this.
Let me share. Could you share the stem booth, which is on the right? Excellent. You see the expansion of the stem. I think it's acceptable. We have a little under expansion where we have the curve, but I would accept this outcome. So let's go to the caudal. Vamos a la caudal.
Caudal.
And I will see if I can do the circ in 10 minutes. I don't know. Okay, only 8. Oops, I don't think so. Give me the Sion Blue. Vaya. Espera un segundo a ver si va esta y.
No, Sion Blue.
La guía, Sion Blue. Need a huge bend now to go to the circ. Let's go. Let's see if with a regular BMW I can cross it. I don't think so. If not, I might need a micro catheter.
So in this kind of plaques with severe tortuosity and calcification, which wire do you think will be the suitable?
Well, we always try with the BMW from the beginning, but then probably Sion Blue is a good option. Fielder XT for tortuosity is okay. Hydrophilic wires could be, but you have to be very cautious about dangerous wires, especially when you are in a live situation. Dame un microcatheter. Let me see this. So we are there, but I don't have pushability. So if you give me the balloon, the 2.0 balloon, probably it's going to help. If not, we are going to change the wire. Dame el 2.0. Here.
Why do you prefer a microcatheter instead of an over-the-wire balloon?
Why?
Why?
First, because over-the-wires are almost not available. And microcatheters, teneme, Carlos, always have better profile.
Okay.
And it's, in some cases, it's much easier to advance microcatheter than balloons due to the profile. And the trackability and navigability are much better.
Okay.
So we will try with this wire, then we are change for the Sion Blue, and then probably we go for a stiff wire, like Gaia or something like this. This is almost subtotal occlusion. Oh, no. Let me see. Pull the balloon. Okay. Hace un tecito, please. Oh, it's so tight and so short the distance I have to cross. The problem is okay, let's change the wire. Let's change everything. Take the balloon out. Give me a microcatheter. Un Corsero, Caravelle, whatever. ¿Tenés ahí?
Sí, acá está. Here is.
Okay, perfect. We have only 5 minutes. I think the important is just crossing, and then the procedure is going to be done. So we are using the Caravelle because it was available, nothing special about that. Hold the wire when you have it.
Listo. Okay. Hold the wire.
No tires. Contala. Poneme un poco de zoom, please. Okay, better. Give me the Sion Blue. You see that the backup of the catheter is awful. Acaba. Y búscame una crossit. Sí. Which is the remaining time? ¿Cuánto tiempo? Okay, 5. Okay.
5 minutes.
Andres, any question or comment from the audience? Any suggestion?
Yes. Would temporary access instead of
Sure, absolutely. guiding support would have been much better from femoral access, no doubt, in this case. But when we finish, the patient is going to be more comfortable, less risk of bleeding, and all the benefits of the radial access. This is the issue. We are uncomfortable, but the patient is going to be better. Test. Sorry. Okay, test. Oh. Give me the crossit. No, Sion Blue is not working. Need a very small bend on the tip. Okay, according to Claudio's watch, we only have 1 minute. Whatever the transmission is finished, we are more than thank you to all of you for helping, for supporting, for watching, for comment, and for everything. I think the case is going to take a few more minutes because we need to cross this tight stenosis. And you know, it's always a matter of time. Crossing. Yes. We are.
Hey guys, we're gonna still record the case, okay?
Okay.
Yeah, so you guys can keep finishing.
Okay, perfect. So thank you to everybody. The case is going to be recorded. But I like to give the transmission on time to my colleagues in Canada or wherever they are going to follow to us. Thank you so much.